So, Assalamu alaikum, everybody. My name is Ishaq Lat. We are back again this week. This session, we wanted to focus on breast cancer awareness. It's timely because it is Breast Cancer Awareness Month. And alhamdulillah, we have two recognized experts within our social circles and within our community that can help speak to the topic to bring awareness for congregants of the community and of the masjid, and also for family members and friends that might also benefit from the information themselves. So let me start by introducing Dr. Neela Alsheikh. Dr. Neela Alsheikh is actually the chair of breast radiology within the Advocate healthcare system, and she's also a congregant of the MCC community. So welcome, Dr. Alsheikh.
Thank you.
We also have Dr. Faiza Vaince. She is a surgical oncologist practicing at Loyola Medicine. She grew up in the Chicagoland area, trained at Rush University Medical Center and also at USC. Thank you for joining us, Dr. Vaince.
Happy to be here.
So I thought it'd be useful for us to get started by talking a little bit about risk factors for breast cancer awareness, or for breast cancer. I think most people tend to think of breast cancer as similar to other types of cancers, where you perhaps have an increased risk based off of family history or based off of exposure or other types of myths. So Dr. Vaince, if you wanted to speak to a little bit, what are some risk factors that our community members should be aware of with regards to breast cancer?
Well, I think the first one that comes to mind for most people is some type of family history. Interestingly enough, though, maybe 10 to 20% of actual breast cancers are associated with a family history, genetic predisposition. Majority of the times it's considered a sporadic case. That being said, family history definitely is a risk factor. So having an immediate family member, so that's a sister or a mother or an aunt with breast cancer, you should be aware that and that's not just breast cancer, but ovarian cancer. So if you have family history of ovarian cancer, that will also increase your risk. But the other risk factors, it's similar to other cancers. So obesity, particularly in the postmenopausal, so elderly women population, and then smoking, alcohol, these are all risk factors for any type of cancer. And so breast cancer is no exception. So some of the other ones that most people are not as familiar with are kind of specific to breast conditions. So if you've had prior breast biopsies that have shown like atypical conditions, that is considered a risk factor. If you have breasts that are on the what we consider denser side, and Dr. Alsheikh can speak to this more as well, that's also considered a risk factor, and that's actually gaining more notice now too, because all of our mammogram imaging will now comment on breast density as well. So more and more patients are, more and more women are now familiar with actually how dense their breasts are or how dense they may not be. And then things like there's factors related to your gynecologic history. So women that have given birth later in life as opposed to women that have given birth earlier in life. The ones that have given birth later in life, that's considered a risk factor, or women who have never had any children, that's also considered a risk factor as well. And all that relates to, your exposure to estrogen over your lifetime. And so that kind of also leads into hormonal replacement therapy. So some women are on hormonal replacement therapy after menopause. And if you're on a combination regimen with the two types of hormones, estrogen and progesterone, that might lend to being a risk factor as well. But, I want to also comment on some of the stuff that's not a risk factor, where a lot of people do think it is a risk factor. Things like, there's not too much we know about dietary risk factors that can be said, if you eat this or if you don't eat this, it's going to cause breast cancer. There's just a lot we just don't know about that. Things like deodorant, certain types of deodorant are not risk factors. The typical radiation that you get with your routine imaging, that's not going to be a significant risk factor. So it's important to note that all of that is not a risk factor. Birth control pills, that your risk typically will normalize after disuse of birth control pills. In IVF, which we see more often now too, in vitro fertilization is not a documented risk factor for breast cancer at this point.
You brought up a really good topic there about myths around risk factors. One of the common things I hear is about cell phone use. Holding a cell phone near your head can cause brain cancer, holding a cell phone wherever. Can you comment on that a little bit?
Yeah, certainly, because your phone is going to be in your breast pocket a lot of times as well. This might be one of those things, time will tell, but right now we have no data to support it, to say that it is a risk factor.
That's good to know. I'm sure a lot of people will be relieved to hear.
Yeah.
Dr. Alsheikh, can you touch a little bit about when exactly to start conducting breast exams and the types of things to look for?
Thank you so much, Ishak and MCC Leadership, for hosting this very important conversation during Breast Cancer Awareness Month. Essentially, every female should have an awareness of her breast tissue because it can fluctuate during the month and from month to month. So what we even see, Faiza and I, see girls as young as 13 or 12 years old with breast masses. So we find that it's very important to have a familiarity with your breast tissue at a very early age. And what we tend to recommend is that, for example, pick a time, for example, the first day of every month, and perform the exam the same way the first day of every month so that then you can notice any subtle changes in your breast tissue. So that may be radiating out from the nipple areolar complex, like in a pie fashion. Certainly feel free to look in front of the mirror and extend your hands upwards so that you can see any dimpling of the skin. But really important things to look out for would be any puckering of your skin, any changes of the skin, what they would call a formation of like an orange peel appearance, any redness, what they call erythema of the skin, any type of nipple discharge whatsoever, such as bloody nipple discharge, green nipple discharge, clear nipple discharge. Of course, if you're breastfeeding, you will have some milky nipple discharge, but anything out of the ordinary for you, do not hesitate to bring it to the attention of your ordering provider. It's always better to seek care than to just sit on something and just assume it's hormones or a hormonal fluctuation. In general, in the US and even worldwide, we see a lot of disharmony in the recommendations for screening mammography. But if you take nothing else from today's session at all, just take away the following: that we recommend screening mammograms every year, beginning at age 40, preferably with 3D mammography. So I myself practice at Advocate Lutheran General here in Park Ridge, which is very close to MCC, and Dr. Vaince practices at Loyola. And at both of our institutions, 3D mammograms are the standard of care. And it's almost like a CAT scan of the breast, where you get multiple slices instead of just the one slice that you would get from a 2D. Circling back to something that Dr. Vaince had said prior, I just wanted to circle back on the concept of dense breasts. What are dense breasts? You may hear about this when you get your mammogram letter back every year. But essentially, when I look at a mammogram, I'm a radiologist, so I look at pictures all day. Sometimes I look at pictures of the brain, of an MRI, and sometimes I look at pictures of a breast from a mammogram. And I'm looking for abnormal white areas. So I'm looking for white spots that could be calcifications or white masses. So when someone is dense, they have a majority of white breast tissue. So it's like looking for a snowman in a snowstorm. And this really complicates the reading of the mammogram, and sometimes cancers can be missed. If you have dense breasts, don't be alarmed. 50% of our population in America has dense breasts. But we have an obligation now on a state level and a federal level to let women know that they have dense breast tissue and that this is an independent risk factor for breast cancer and can confer an increased likelihood for breast cancer. And for those women, we have other tests that we can perform at the time of the screening mammogram, such as a screening ultrasound. And in some cases, if a patient has a high family risk, over 20% lifetime risk, we can also perform a breast MRI. So just something to be aware of. Lots of information in a short time. Apologies for that.
No. That was excellent information. We really appreciate it. One of the things I found beneficial in speaking with both of you is that you both have, mashallah, like a lot of really good information and knowledge. If you're a community member, what are the types of things that they should look for when they're looking to try to choose the right doctor for them?
So, I can start that off, Neela. Ultimately, if it depends on what you're looking for. So if you've got a breast cancer diagnosis, especially if you're in this area, we're fortunate enough that there's specialists focusing on this area. And you can go to somebody who only focuses on breast cancer. So that's one thing. But ultimately, if you're looking for somebody who just you want to talk to them about your breast health, that could be your regular primary care physician, or that can be a gynecologist typically. And I think usually with the recommendations is at age 25 is when you want to start talking to your doctor about your own personal risk. What is your risk for developing breast cancer? And your doctor can work through your risk factors with you. And that is how you're going to come up with the game plan of when you're going to start your first mammogram and when you're going to start any additional screening measures like Dr. Alsheikh alluded to. There's other options, not just mammogram. We do ultrasounds and MRIs if you actually do have a lot of risk factors. So I would say, in your mid-20s is when you really want to start aligning yourself with a physician and talking to them about your breast health in addition to all your other health conditions as well. And then just, circling back to if you are diagnosed with breast cancer, I think it's just really important to talk to physicians that are up to date with all the options. What's nice about breast cancer is, and this is what drew me to go into it, is it's a very dynamic field. There's a lot of money that's poured into it and a lot of research that comes out of it. And with that, there's a lot of nuances to the management of the disease. And there's a lot of new treatment options that are constantly coming out. So you really want to make sure you're paired up with a physician that's going to be up to date with all the options, but is also reviewing all the options with you. So they're not just making assumptions about what they think might be good for you. We sometimes corner our patients, particularly if we're from a certain culture and our patient is from a certain culture. It's easy to make assumptions what we think that patient might want, but often I've been surprised by what the patient wants and what I thought they may have had. So it's really important to review all your options with the patient, and then if they are really seeking guidance, then you can start lending them more discrete recommendations. So they really have, you're looking for a physician that's not just treating the disease, but is also taking into consideration the entirety of the patient.
Cool. Dr. Alsheikh?
I agree with Dr. Vaince wholeheartedly. I think the most important thing is to look for a physician who's a good listener and who's going to meet you where you are on your journey. Obviously, all of us try to practice according to the standard of care. We have the wealth of opportunities being in the greater Chicago metropolitan area, of having a lot of innovation in this area at our respective institutions at Loyola Healthcare and at Advocate Aurora Health. However, only that patient and her family know where they are in space and time at that specific moment. Our job is, we know the evidence-based data, we know the science. Our job is to present them with options. And it's not a one-size-fits-all model. So what may work for one patient does not work for another. A breast MRI that takes 45 to 60 minutes in one patient may induce significant claustrophobia in another. So we have to provide them with options and meet them where they are. The other, the other facet of listening, the other side of the coin is, communicating. And so oftentimes, and I'm sure Dr. Vaince is, aware of this too, that when patients come in, oftentimes they may only hear 5 to 10% of what you're actually counseling them. So they may have to bring a family member with them. They may have to come multiple times, but it's our job to just counsel them and speak with them, and as many times as necessary, until they have a thorough understanding of the treatment plan and the diagnostic plan.
And to that end, I would say don't be afraid also to ask for interpreters. All hospital settings have interpreter services. And in fact, we as providers actually prefer non-family members, particularly in something as serious as a cancer a conversation, to have a third party doing the interpreting for the patient.
That's great information. Dr. Vaince, I was going to ask you a little bit regarding therapies should someone be diagnosed with breast cancer. Can you touch on a little bit about what the different types of therapies there are and some of the advancements in the options that are available?
Yeah, so generally speaking, when you're treating breast cancer, there's going to be 3 components of treatment. It's going to be surgery, and then there'll be what the medical oncologist will talk to you about, which include potentially a pill or chemotherapy or both or neither. And then there's radiation treatment as well. So generally speaking, a breast cancer patient will probably at some point during their journey meet with all 3 types of doctors. And when you meet with the surgeon, of course, they're going to talk to you about the different options, but usually it comes down to, either preserving your breast and just removing a part of your breast versus removing the entire breast. But they should understand that with either option, plastic surgery is also part of the picture, and that's also covered by insurance. So if they're getting some reconstruction, that will be included. When the medical oncologist is talking to the patient, they are specifically, they want to know what type of breast cancer the patient has. So it's not just the size of the cancer or the stage of the cancer, but more importantly, it's the type of breast cancer. The majority of breast cancers are the type that respond to estrogen. And so for that reason, ultimately, a lot of these patients qualify for a pill as part of their treatment plan, which is great because sometimes patients shy away from getting more aggressive treatment originally, or may not be in the best state of health. But if their cancer is the kind that responds to a pill, at least in the meantime, they can at least go on a pill to stop the progression of the disease. And then, of course, chemotherapy might be indicated for certain more aggressive types of breast cancer, or even if it is an estrogen receptor or a hormone receptor positive cancer, if it's really advanced, then you're going to probably need chemotherapy as well. When we talk about targeted treatments, again, the medications are getting better and better. And it's all tailored to the actual biology of the cancer. And so now we're sending off our cancer for more what we call genetic profiling. And so you get more information about your actual cancer. And it's, just like no patient is the same, no cancer is the same either. And so this allows us to more tailor our treatments. And now more patients are not getting chemo because of these genetic profiling tests. We're able to determine which cancers don't necessarily need chemo. And we used to throw chemo at these patients. So that's a nice thing. And then even with the radiation, radiation treatment has really evolved. It used to be 5 to 6 weeks was the standard course of treatment, where they would have to come in every day, Monday through Friday, for 10 to 15 minutes to get their treatment. Now the standard has scaled back to 3 weeks of treatment. And then they have also one-time doses of treatment options as well. So again, that's what's nice about breast cancer. The treatment is evolving, and generally speaking, it's becoming less and less invasive.
It's really helpful because I think most people, myself included, tend to think of breast cancer being treated only with chemotherapy, where people lose their hair. And I know that's a serious concern for a lot of community members and women in general about the side effects of chemotherapy. Right. So it's really important to understand that not all breast cancer is treated with just chemotherapy. A majority of them now are treated with multimodal, different types of options, and a pill included.
Yeah, I would venture to say, most stage 1 and stage 2 cancers actually don't end up getting chemotherapy. And the other thing to clarify is a lot of people hear radiation too, and they think they associate that with chemotherapy, but radiation is a separate thing, and it doesn't make you lose your hair, and it's more of a finite period of side effects.
That's really encouraging to hear and really helpful. I wanted to wrap up a little bit talking about cancer survivors and the benefit perhaps of developing networks. Can you all touch on a little bit about things that you've seen out there in the community that perhaps we can adapt to a Mujahid community or a Muslim community within an urban area like ours?
Absolutely, yes. It's very important both in the short term to get through the short term sort of side effects of radiation and surgery and so on, and to know the road ahead to get together with survivors, but also in the long term, it fosters a lot of spiritual and emotional and even physical support over the long term. So there are multiple things we can do. We can have survivor groups at our masjid, both in the preoperative setting and the postoperative setting, into long-term survivorship. I would also like to offer myself as a resource. I know that you said in the beginning of the call that the masjid is, mashallah, offering flu shots. We could also have a session where we actually sign people up for mammograms so that they can get their appointments. One thing I tend to see in our communities and more diverse communities at large is that there is a delayed presentation for screening mammography. And I do see people presenting for their first mammogram even at the age of 67 and 70. And, with this being 2020 and the United States and the wealth of, innovation and technology we have, although of course all of us put our trust in a higher power and trust that he will take care of us, I quote one of my favorite hadith, which is that we have to tie our camel first and get that preventative testing. Yeah. And, and so we can have a health fair potentially at the masjid and sign people up for mammograms, or even counsel people on what a mammogram would look like, or what compression could feel like, or how long it lasts. So those are a few of the things that we could do. But yeah, I would like to sort of offer myself as a resource that if anyone were to have a symptom or a question as to where to go or which facility is closest to them, or how even to schedule a mammogram or a surgical appointment with an expert such as Dr. Vaince, that we could help them set that up.
Yeah, I would echo the exact same thing. The resources are there. It's just a matter of us consolidating our efforts so that they're accessible to the patients. And with initiatives like this is going to help spearhead, the support groups, developing those support groups within each masjid, having the database of patients, survivors, and also experts within the community. There's experts within every masjid community that can help guide us. But the other thing that Anila touched on is just the access to mammography. I think it's just really daunting to patients. I think that there's a big cost associated with mammography, and to my understanding is the cost is not as substantial as some of these other radiology tests. And so I think we just need to put that out there, like, hey, this is how you can get a mammogram. Even if you don't have insurance, this is how you can do it. These are the routes to get the initial mammogram, and this is the cost to anticipate.
And you're right, Dr. Vaince, at our institution, we don't even need an order for a screening mammogram. A patient can just walk in and self-refer. And secondly, my understanding is that under the Affordable Care Act, that there is no cost associated with mammograms. And we do have a Senate bill in the state of Illinois, Senate Bill 466, that covers mammograms and 3D mammograms completely. So with no cost sharing whatsoever to the patient. So very important to just advocate for yourself and to come in. Now, if you're an immigrant and do not have citizenship status, the city of Chicago has established that you can call 311. And there are resources by calling that hotline where you can get a voucher for a free mammogram. And if you need any ancillary testing at all, such as biopsies or MRIs, you can get vouchers and go to institutions that honor those vouchers, and we can certainly help with that. Wow. So we just want to provide to the extent we know we have we're blessed to have an immigrant community. We may have citizens, we may have not citizens, but we can get you the help and the testing that you need.
That's amazing information.
Thank you.
With that, I wanted to thank you both so much for your time. I know that we're all doing this at the end of our work days. I'm sure when people watch this, they'll perhaps be able to sort of put that into context. But this was amazing information. Thank you both so much, Dr. Alsheikh and Dr. Vaince. Inshallah, we'll try to follow up soon and perhaps be able to organize a session around this topic.
That would be wonderful.
Thank you so much.
Thank you for hosting. Thank you, Dr. Vaince.
Thank you.
Thank you, Ishaq. Thank you.